From the JAMA Network, this is JAMA Dermatology Author Interviews. Conversations with authors exploring the latest clinical research, reviews, and opinions featured in JAMA Dermatology.
Hello and welcome to this author interview from the JAMA Network. This is Dr. Adamson, the web editor for JAMA Dermatology. Cutaneous squamous cell carcinomas are the second most common malignancy in the United States. Although it typically carries a good prognosis, a subset of squamous cell carcinomas are highly aggressive, carrying regional and distant metastatic potential. Despite being a commonly diagnosed disorder, cutaneous squamous cell carcinomas are not routinely tracked by cancer registries. And as a result, many studies of squamous cell carcinomas are single center or multi-center with a lot of variation in reporting and analysis, thus limiting their generalizability. In a new study in JAMA Dermatology, an expert panel was convened to determine standardized guidelines for reporting measures for retrospective studies of cutaneous squamous cell carcinoma. Dr. Shahwan is a board-certified dermatologist and Mohs surgeon, an assistant professor in the dermatology department at The Ohio State University Wexner Medical Center in Columbus, Ohio. She's the senior and corresponding author of this new article and is here to discuss the work. Welcome to the podcast, Dr. Shahwan.
Thanks, Adewole. Thanks for having me.
Can you tell us a little bit about what your role or your upcoming role is at Ohio State?
Absolutely. So I did my Mohs surgery fellowship at OSU back in 2020. Really wanted to stay on as faculty, but unfortunately it was COVID time. So I ended up taking a job in North Dakota due to hiring freezes and low surgery volumes, things like that. Just bad timing, but really wanted to stay involved with OSU because I had started a lot of research endeavors there and really loved the faculty and residents and patient population. So ever since then, I have been sort of traveling back and forth, working in both North Dakota and OSU. Very excited and lucky to be going back full-time this September as a full-time associate professor in the fall. I'm a Mohs surgeon there, and then I'm also going to be running a transplant skin cancer clinic where I do skin exams on, of course, transplant patients as well as people at risk of high-risk skin cancers.
Did they have such a clinic before your arrival? Are you starting a new one, or you just kind of joining one that has already started and is kind of expanding?
So they already have two faculty members, one who is a Mohs surgeon and one who's a general dermatologist who both run high-risk skin cancer clinics and transplant clinics. So I will be the third clinic in the department.
Why is it worthwhile convening a group of experts to come up with these measures? Don't we already have measures that we report in retrospective studies related to squamous cell carcinoma?
So as you mentioned, the literature for high-risk squamous cell carcinoma is really limited by the sense that they're not included in national tumor registries because the sort of general thought amongst many specialties, but even amongst some dermatologists are, squamous cell carcinoma, it's not a big deal. Most of these are highly curable. It's not necessarily something that we have to really worry about as having poor outcomes. But we really do know that a subset of these are aggressive and do have poor outcomes. So the importance of the study is really to be able to accurately predict and risk prognosticate which tumors are going to go on to have these poor outcomes. So I ended up attending the ITSCC, which is the International Immunosuppression and Transplant Skin Cancer Collaborative, a really great international organization that includes dermatologists, dermatologic surgeons, and even clinicians from other specialties related to transplant medicine. They host every other year a biennial fall symposium, and it's just a wonderful meeting, and a lot of different work groups and research efforts start or come out of this meeting. This is just one thing that ITSCC offers. I highly recommend everybody join because they have a lot of great resources, networking, and mentorship programs for all dermatologists who are interested in transplant medicine. But one of the highlights is definitely this biennial fall symposium. So this was one of the work groups that was started at the 2022 Fall Symposium that was determined by the ITSCC, board of directors and the leader of that meeting as being an area where we could really make a difference here. A lot of different institutions, OSU where I'm at included, have their own single center retrospective databases that can be used to perform outcomes-based research. But the problem with these are because the overall risk of poor outcomes in squamous cell is quite low, it's difficult to get enough power in these analyses to really have meaningful statistical analyses. So what we really need to do is pool data from multiple institutions in order to have enough poor outcomes to see enough power in our analyses to really draw meaningful conclusions. So at this work group at the fall symposium, it had been determined that a sort of a prerequisite for pooling that data was to make sure that different institutions are collecting and recording these in similar ways. So that way it's a lot easier to pool this data and make meaningful conclusions.
So in previous papers that people have published, there have been a lot of different ways in which people have collected data. Could you give an example of some ways in which studies may collect information differently and how that could potentially have implications for the lack of generalizability?
So just a couple of examples. One would be determining an index tumor for a poor outcome. So if you're sitting there and you're putting in patients into your retrospective database, you may come across a patient that has had nodal metastasis, distant metastasis, and even passed away of their squamous cell carcinoma. But then you look back at their primary tumors, and some of these patients might have anywhere from 10 to 20 or even more primary squamous cell carcinomas. So the difficulty there becomes, how do we decide which of their primary tumors ultimately led to this poor outcome? And that can be actually very, very difficult to do when they have multiple tumors, especially if multiple of them have high-risk features. So we wanted to give researchers who are doing this type of work the tools to sort of decide which tumor is most likely to be that index tumor to help aid in those analyses.
And what about recurrence? Another focus of this work group, or something that came out of it, was how to define what local recurrence is. Does it have to be at the site where a biopsy happened or where an excision happened? Is it within a certain distance from that scar? How is that defined?
Yeah, so this was actually previously described by Justin Leitenberger and his group. They did a really nice paper clearly defining local recurrence. So our panel actually decided to use that exact same definition that had been described previously. So to call something a locally recurrent squamous cell, it should have similar histology to the primary tumor, and it should also be contiguous to that three-dimensional surgical scar and arising within the area of a previously treated tumor. So if all three of these are met, you can very confidently say that this is a local recurrence. If only some of them are met, it's a little bit more unclear. So you have to sometimes use your best clinical judgment in whether or not to include that in the locally recurrent group.
So what other variables or features did your group find important in terms of the standardization of how things should be measured and reported for these types of studies?
Another interesting area is that of satellite in-transit metastases in cutaneous squamous cell carcinoma. So this is something that's been really well studied in the melanoma and the Merkel cell carcinoma literature, but we just have a few early studies showing that satellite and in-transit metastases have a very high risk of poor outcomes. And one study using the Brigham and I think also the Cleveland Clinic cohort, it showed that the outcomes for tumors with satellite in-transit metastases were also very similar to those that have nodal metastases. So these are really high-risk tumors. How to identify and record these can be very tricky and nuanced when you're doing some of this retrospective database work. So the official definition, we thought using that AJCC 8 definition applied to melanoma would make the most sense. But the panel actually had a little bit of initial disagreement on whether these should be recorded together or separately, because in the squamous cell carcinoma literature, they've always been grouped as sort of one entity. They have never been shown to have a different prognostic implication between whether they're satellite, which is, within their 2 centimeters of the primary tumor, or if they're in transit, which is greater than 2 centimeters from the primary tumor. So after some discussion, our official recommendation was that it's best to record them separately if you can, because it's a lot easier to combine them in analyses, but then allows us to do future studies looking at whether there is a difference in prognostic implications between the two. Another interesting one was parotid metastases. So these are sort of a gray area sometimes. If you have a patient with a squamous cell carcinoma on the cheek and it's growing into the parotid, some institutions or some recorders of this data may count that as parotid metastases. Other institutions may count that as direct extension. So one thing we did was clearly define that if it's growing directly from, say, the overlying cheek skin into the parotid, that should not be considered a metastasis. It should be considered direct extension. However, if it's separate from the parotid area and you're now getting tumor in the parotid, that should be considered a regional metastasis. And then the other tricky thing can be, if the parotid itself is involved, as well as the periparotid lymph nodes, what type of metastasis do we consider that? Is that a distant metastasis or is it a nodal metastasis? So these really should be considered as two separate entities, but they do often occur together. And we also felt that they should be considered as regional metastasis rather than distant metastasis.
What are you hoping for how this study gets used in the future?
So I think any institution that's interested in doing this type of work and wants to start a retrospective database at their own institution, our hope is that they will use some of these guidelines as they're recording. It will be very helpful in the sort of day-to-day putting in of the data, because these are questions that come up a lot, especially if you're having trainees or medical students that don't have as much clinical experience managing these really complex patients. It will help answer some of their questions about how to best input this data. But much more importantly, with greater implications, is the more standardized that we can have these databases be, the easier it is to then pool that data and get much higher power and more meaningful analyses. So we actually now have a pooled database of 12 international centers. Many of the experts who are participating in that effort were also on this expert panel standardizing these reporting measures. So this expert guideline panel really helped us to pool that data in a way where it made a lot more sense to combine measures and help to sort of minimize things being recorded differently, which makes it a lot harder to combine the data. We've recently pooled everything. We have a database of over 20,000 tumors now from 12 centers.
So you're hoping to grow that, and you're hoping that these guidelines will help with that growth.
Exactly. The more data that we can have with this, the better, since we don't have access to national tumor registries.
Actually, as I was thinking about your study, it sounds a lot like you're putting together, in some ways, a coding manual for people to use in order to properly collect data, right? In the same way, standard national registries have manuals and guidelines for people entering data. Do you have a different perspective or maybe a newfound respect for some of the challenges in trying to develop these kind of guidelines for people to use?
Definitely. I think I really gained that respect back when I was the Mohs Fellow, actually putting in these patients into our own OSU database. A lot of this stuff, you read this paper, it might sound like kind of common sense, but when you're actually sitting down putting in some of these really complex patients, it can be really challenging and really nuanced as to how to categorize or define some of these things. Our hope is that putting this in writing, having, a group of experts that are really familiar with this work come together and clearly define some of these things will help institutions who are maybe just starting out in getting a retrospective database to make it a little bit easier and then be able to pool that data later on.
I'm Dr. Adamson, and I've been speaking with Dr. Katie Shahwan about standardized reporting in retrospective studies of cutaneous squamous cell carcinomas. You can find a link to the paper in this episode's description. This episode was produced by Shelly Steffens at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us at jamanetworkaudio.com. Thank you for listening, and we'll catch you on the next episode of the JAMA Dermatology Podcast.